Hi, everybody. Thanks for joining us today. My name is Rachel Rosen. I'm the director of the Aerodigestive Center at Boston Children's Hospital. I'm also a gastroenterologist, and today I have an amazing panel of folks joining me today. Today, we're going to talk about taking care of children with complex medical needs in the Aerodigestive Center. In the Aerodigestive Center, we take care of kids with gastrointestinal problems, pulmonary problems, and feeding and swallowing issues. And our panel today represents this diversity of care providers. So just to introduce everybody, today we have Dr. Arda Hotz, one of our complex care pediatricians, and she takes care of our children in the hospital with the most complex medical needs. We have Dr. Tregony Simino, our pulmonologist in the Aerodigestive Center, who has expertise taking care of not only aerodigestive patients, but also patients with severe asthma. We have Lisa Hester, our clinical coordinator in our Aerodigestive Center, and Tony Solari, our nutritionist in the Aerodigestive and Motility Center, who has expertise with blenderized feeds. Okay, so we have a lot to talk about today. So Dr. Hotz, you're going to be up first. You play a critical role in our Aerodigestive clinic and in the hospital. Can you talk a little bit about what it's like to be a complex care pediatrician and what type of patients you see?
Yeah, I'd love to. So my name is Arda Hotz. I'm a complex care pediatrician at Boston Children's Hospital. That kind of means that I'm a general pediatrician who specializes in working with children with special healthcare needs and with medical complexity. As a complex care provider, I don't replace your child's pediatrician, but I work alongside the pediatrician, your child's medical team. Many PCPs or pediatricians work outside of our system and don't have as much experience working with children with medical complexity. So it can be helpful to have a generalist looking at the whole picture of the child. We help coordinate care, collaborate with specialists, and identify gaps of care. I work with the Aerodigestive team, collaborating with all of your child's specialists to support the patient and their families. And we try to help optimize the child's abilities and think outside the box to support each individual patient. Many of the patients we see in Aerodigestive clinic through complex care are medically complex. They need medical equipment such as G-tubes, respiratory support, or wheelchairs. The patients we follow really closely to monitor and support because we understand that there may be conditions that they may have unique risks for, such as aspiration pneumonias.
That's great, Dr. Hotz. And that's a perfect segue to Dr. Simino. Dr. Simino, as Dr. Hotz mentioned, a lot of our kids have swallowing issues and put them at risk for aspiration. Can you talk a little bit about the role of the pulmonologist in caring for kids who aspirate?
Yeah, so my main concern with chronic aspiration is the risk of injury to the lungs. So we know from previous research studies that larger volumes of aspiration into the lungs causes significant damage. But with chronic small volume aspiration over time, that leads to inflammation in the airways. And that can make children more prone to respiratory illnesses. They may have wheezing, and then it can also lead to pneumonias. So kids who have swallowing dysfunction may also aspirate when they vomit or if they have reflux. And saliva is also a thin liquid that can be aspirated and then can also lead to some of those changes in the lungs. And that can also result in an increased risk of pneumonia. Additionally, children who are medically complex may have other lung problems that may make them more susceptible to severe respiratory illnesses as well as pneumonias. For example, children with scoliosis may have trouble effectively clearing their secretions. So to help address these issues, we'll often use nebulized or inhaled medications to help with airway clearance. And for those who aspirate saliva, we try to minimize or thicken secretions. And then we work really closely with our GI colleagues to help minimize any vomiting or reflux. And ultimately, our goal as a team is to develop the safest feeding plan that's going to protect the lungs, but also honor the priorities of the family and the child.
That's great. And that brings up a really good point, Dr. Simino. You mentioned ways to feed patients that sometimes can minimize the risk of aspiration. And I think, as Dr. Hotz mentioned, a lot of our kids are technology dependent and come to us with gastrostomy tubes and GJ tubes. Lisa, do you want to talk a little bit about the different ways that we see kids being fed in the Aerodigestive Center, in particular in kids at risk for aspiration?
Sure, I'd be happy to. In our aerodigestive patients, oftentimes they can't, either if they can't safely take things by mouth, or if they're not able to meet their nutritional needs all by mouth, oftentimes we will need to use enteral tubes. We do have a couple of different types of enteral tubes that we can use to help maximize the child's care. One of the tubes is our nasogastric tube. This is a tube that goes directly from the nose into the stomach. This tube we often use as kind of a bridge to a more stable type tube, but there are some benefits to an NG tube, one being that it does not require anesthesia to be placed. It can kind of use as a temporary basis where it can kind of take it in and out. But one of the negatives to it is that it can be easily come out, which can be troublesome for families because it may require ED visits or coming into the hospital for replacements. So oftentimes we will try to use a more stable type tube, like a gastrostomy tube, which is a tube that goes directly into the stomach. There's a lot of benefits to a gastrostomy tube for our type of patients. It gets the tube away from the face. So sometimes it can help us work on some oral feeds if it's safe. One of the other things is we can also use thicker feeds into the gastrostomy tube, which we cannot really use in an NG tube. Just because the diameter of the tube was so small with an NG that oftentimes we need a little bit of a larger tube with a gastrostomy tube. So we really had a lot of benefit with thickened feeds into the stomach for some of our patients. The other thing with a gastrostomy tube is parents can learn to replace it at home. So it doesn't require a trip to the office or a trip to the emergency room once we've taught you how to change it. But in some of our more complex patients, sometimes vomiting and reflux can be a big issue. So we need to think of other ways to feed. And one of the other ways is with a GJ tube. So it's a tube that kind of, you see it outside the stomach, but it has a port that goes from your stomach, but there also has a port that goes into your small intestines. The benefits of this type of a tube is it kind of bypasses the stomach. So we can, give most of the nutrition into the intestines. And so there's not as much volume in the stomach, so less likely to reflux or less likely to vomit. But there are some downsides of the GJ tube, one being that you can use some of the thicker feeds, but we have to be really careful about how thick the feed is, because the formula needs to be a little bit thinner because the diameter is much smaller than a G. Also, you have to do continuous feeds with the GJ tube. Because, our stomach is meant to kind of take more boluses. So like it's meant to stretch, but your small intestines are really meant to stretch like that. It doesn't hold things. So you need to do kind of slower feeds, which requires being attached to a pump sometimes a little bit more. So in our center, G tube is kind of where we like to do with blended feeds. And I think we have someone on our panel should help kind of talk more about that.
That's great, Lisa. Thank you. And that's a perfect segue to Tony. So when I think about where the aerodigestive field has really progressed over time, I think one of the biggest, I would say, advances that we've had in the care of aerodigestive patients is the use of blenderized feeds, which have really revolutionized our care of children with medical complexity. Tony, do you want to talk a little bit about our experience in the center and how we choose what kids are fed?
Yes, thank you. So yes, we do a lot of blenderized diets or blended diets in our center. And just to clarify what that means, when we say a blended diet, it's the pureeing or blending of real food ingredients and being able to deliver that to the patient through a G tube or through a gastrostomy tube. I'm going to be focusing mostly on G tube blends today. So the reason we like using blenderized diets is that they tend to be thicker, and the thickness or the viscosity of a blended diet can be really helpful for our patients who have reflux and vomiting, because it can really minimize that, which better protects the lungs. Another reason why we really love blended diets, being in a GI heavy clinic or gastroenterology heavy clinic, is that the fiber in real food ingredients tends to help with stooling. Also supports a healthy gut, and good gut health can be helpful for overall health. And I also find that we as a team find that families really like a blended diet, because sometimes they come and they find that their their child now cannot eat foods by mouth, and they kind of miss that table food friendly diet. So this allows a family to mix up some of their ingredients that they would normally eat by mouth and still give it to their child. So on that note, we work a lot with families to create a recipe using their homemade food, their home-based foods, but there are also other products on the market that you can get from your medical supply company that are blended nutrition as opposed to your standard commercial formulas. So I could go on and on of why we like blended nutrition, but I will stop there for now. If you do have an additional interest or want to hear more about blended nutrition, we did create a mini series of videos that talk a little bit more of how we use blends.
That's great, Tony. Thank you so much. So we have gotten quite a bit of questions that were emailed to us before the start of the webinar. So I'm going to start by tackling some of those. Dr. Hotz, we got a question about, you mentioned that you interact with primary care physicians. Can you talk a little bit about kind of what that communication entails, and when do we know if we reach out to you versus our primary care?
Yeah, I think this is a great question. And I think I interact a little bit differently with different, depending on the situation. Many primary care providers will reach out to me directly for help with medical decision-making. So sometimes this will happen in the setting of the child being seen in urgent care, or in their practice, if their practice is out of state, and they'll kind of tell us, okay, well, this is what's going on, and what would you suggest to do? And I think given the complex care physicians' expertise in working with some of these more unusual conditions, we're in a little bit more, a better place to provide guidance on what to do next, when a child should be seen a little bit sooner, and sometimes help with decision-making in terms of antibiotics. I think the other things that I play a role with in helping the PCPs are helping them understand resources in the community that may be specific to children with special healthcare needs, because most of the kids that I work with have medical complexity. I am just a little bit more knowledgeable about what's out there to support kids. And this could be in terms of home care, different durable medical equipment they maybe qualify for, or kind of community organizations that they may be a good fit for. And then I think lastly, the other thing I think of myself in terms of how I help PCPs is helping them to understand what a child might be at risk for. Since some of their conditions that patients have are a little bit unusual, and you know, a PCP may see a child with that condition once or twice in their career, it could be helpful to have somebody who has seen dozens or more of that condition. And so I can say, well, from my experience, you know, this is what we worry about, this is what we need to watch out for. And these are some of the healthcare supervision things that we would recommend to help them provide the best general pediatric care.
That's great. Thank you. Dr. Semino, we have a tricky one, and this often comes up with how do you know if it's a GI issue or a pulmonary issue? Somebody emailed a question about my child had a pneumonia, and there's a disagreement among their providers whether it was an aspiration pneumonia or just a run-of-the-mill pneumonia. Can you talk a little bit about how you decide and how Aerodigestive as a team might help sort that out?
Yeah, that is a really challenging question. And I think often people may feel unsatisfied by the answer because there isn't a clear-cut way to tell. So we often presume in people with swallowing dysfunction that any pneumonia could be an aspiration pneumonia. Even in the setting of just a viral illness, if someone has increased mucus, increased secretions, and they have swallowing dysfunction, that could also lead to more likely to turn into an aspiration pneumonia in someone who has swallowing difficulties. So we'll often treat pneumonias as if they are aspiration pneumonias. And that really only means just choosing a different antibiotic. But ultimately, what we look at is the bigger picture of, are these pneumonias happening recurrently? So especially with recurrent pneumonias, we are more suspicious that this may be related to aspiration, as opposed to if someone gets an isolated one-time pneumonia that, maybe their sibling also got, or, that seems to clearly be an infectious origin.
Yeah, that's a great point. And I think just a quick shout out to our Aerodigestive team, where we have both an outpatient team, but also an inpatient team who can help providers, both inpatient and outpatient, to help try to sort that out. And sometimes it really takes a multidisciplinary team to maximize the GI parts, maximize the swallowing parts, and maximize the pulmonary parts all together to try to help sort that out. Tony, a question for you. Can you use blends in kids with food allergies, and can you use blends in kids with hypoglycemia?
Yes, I'm happy to share that those are two things that we are able to work with patients on. One of the great things about blends is you can really personalize the plan for the patient, which I think our clinic really needs. Not every patient has the same set of issues that they're faced with. So we use hypoallergenic ingredients. We can really tweak the recipe however we wish. Oftentimes that's using dairy-free milks, such as oat milk we use a lot. We can use nuts or not use nuts. So really whatever the allergens are, we can address. When it comes to blood sugars, that's something that we do see a lot with our patients, just being able to look at the breakdown of their diet and see where they might need more carbohydrates or more protein, less fats. Again, just going back to the fact that blends really help us personalize for our patients. I hope I answered that for you.
That's great. Thank you. And Lisa, we have a question about the logistics of giving blends through G-tubes. So there's a question about the size of tube that's required. And is there anything special that I need to do differently when I'm feeding my child a blend from a tube care perspective?
Yeah, that's a great question. We try our best, even if it's a 12 French, to try to get that blend through the tube. Sometimes we're not able to quite get it through a 12 French. So ideally a 14 French or higher is usually the best. But sometimes we can do little things like baby food and cereal into a 12 French. But ideally, we try our best to we sometimes have to add a little water to kind of push it through. We also have a lot of tricks for like coating the syringe with like Pam to kind of get it so we can push the feed in a little faster, because sometimes it's hard as actually getting it in can be a little bit difficult. But that's a great question. I mean, we try our best, even if it's 12 French, to get in a blended feed. Oftentimes we can upsize if needed, and we've had a lot of success in clinic in upsizing tubes if needed. But we definitely work with the patient to try to meet what they need with the blends.
And that gets us to another question, Tony. This one is for you. And it's a topic that Dr. Simino and Dr. Hotz and Lisa and Tony and I all deal with a lot, which is my primary care told me my child needs extra water to treat their constipation, and we're adding it to the blend. Tony, can you weigh in a little bit on our approach to fluid in the Aerodigestive Center and the implications from an aerodigestive perspective?
Yes, we get this a lot. And actually, we find that adding water to a blend and thinning it out actually can worsen symptoms of reflux. And we don't want vomiting or reflux because that poses a higher risk for the lungs. So we would not recommend adding a lot of water to our blends. We like them thick. And we find that actually a lot of the typical equations that providers use for hydration for patients, it's just a rough estimate. And when we pull back on some of that calculated water amount, we find that our patients do quite well. They show no signs of dehydration. I'm sure the doctors on the call can weigh in on that, but we find that they're still urinating okay and are not in fact dehydrated with less water.
That's great. That's great. And I know we're getting to the end of our webinar today. We just today wanted to highlight the complexities and the importance of multidisciplinary care and taking care of children with aerodigestive issues. And the importance of communication with all the providers, especially if you have a child with complex medical needs. If there's any questions about the Aerodigestive Center, you can find information about us on the Boston Children's Hospital webpage, and feel free to reach out to us either through the webpage or by phone. We look forward to hearing from you guys. Thanks for joining us today.